You know, I think that just the point that progressive MS is so important and such an unmet need is extremely important. Some of the things that are coming out are really whether there is a major role of the immune system in it. Of course, people have argued about one type of immune system for relapsed remitting, and now they're arguing for a different type of immune response, the innate versus the adaptive immune responses. And whether the innate immune system is really central to the development of progressive MS. I think that's interesting. I think whether progressive MS is primarily due to the reactivity of the innate immune system versus whether it's really more of an independent neurodegenerative process is an important question. And of course, these two are not mutually exclusive. It could be a combination of the two. So it's primarily neuronal or synaptic degeneration that is accompanied by microglial activation, which then in turn feeds into a vicious cycle of progression. I think that when you look at the onset and how they actually do the secondary progressives and the primary progressives, I'm not so sure there really is that big of a difference. I think that we just have missed those early relapses in the primary progressives that maybe they've been silent or for whatever reason they haven't been reported. But I think as we kind of evolve on the issue, I would more or less tend to lump them in the same category, and that is that they are having this disability progression without relapses, and we need to focus on that mechanism. And I want to get out of the terms, some of these terms that have been based on clinical observations that are whether you report them or whether you don't, and I think they're less important than the bigger clinical observation is these people have disability that's accumulating and they're not having very many relapses anymore, and that's really the main thing that we should focus on. And doing so, I think you realize they're probably the same, more or less, with respect to pathogenesis. B cells are a type of an immune cell, and of course there are T lymphocytes and macrophages that have been implicated a long time as being involved in MS. Now people have talked a lot about B cells, although honestly they were talked about really decades ago when people were studying B cells, and they did think that they had some role but not primarily the role, principally in mediating demyelination. Now they find that the biggest data to date, of course, is the new treatments that some of them target B cells and they seem to be having effects. I think the issue there is going to be, are they having effects because they really are affecting the neurodegenerative process, which is kind of unlikely? Or is it because there is some level of inflammation, even that involves B cells, not just the more innate immune system of microglia, but actually some that it does involve B cells that's contributing to this process? And that's, of course, what people would argue. But I think that the time will tell whether how effective anti-B cell therapies are in the really, really purely late progressive stages versus the more earlier progressive stages, and that will tell. I think there's going to be a lot of excitement because there are no FDA-approved treatments for primary progressive or secondary progressive, and so there will be a lot of interest in doing so. My concern will be how effective will it really be when some patients take it that really have absolutely no evidence of inflammation, and if they're at a certain stage, even in the progressive phase, whereby they may not be helped as much. And I think the risk-benefit ratio will have to be weighed, and there's always going to be a lot of excitement in the early days, but it's going to be expensive and it's going to have toxicity issues, and so we're really going to have to weigh the benefit in some of these late progressive patients. How much they're going to get better. It's hard to imagine really repair or improvement in this sort of a B cell therapy like you would if you had something that could remyelinate or cause synaptogenesis. These kinds of things you can get excited about, not just halting progression or disability accumulation, but actually making a given disability better. So that's a whole new arena, and I don't think this is going to fall into that category, unfortunately, based on mechanisms. No, I don't think it's frustrating at all because I don't think people have looked yet. I really think the focus was, if you look at the history of MS, it was thought to be really purely autoimmune, and very little attention was paid to the CNS. It was thought of as like the skin and psoriasis or the joints and rheumatoid arthritis, and it was just a target organ. And so not a lot of thought was put into, honestly, the CNS processes. It was all put into the immune system, and rightly so, because that sort of school of thought gave rise to very important therapies that we have to treat inflammation. And for all practical purposes, we thought that when you treated inflammation, you would halt progression. Unfortunately, the next level to or the next chapter in the book was that after you treat the inflammatory response, the adaptive immune response specifically, relapses decrease, but unfortunately, progression can continue. And so I think only after you can appreciate that, only mere modest effect, can you start to say, hey, there's something going on beyond the anti-inflammatories, and now we need to look. And I think now that people are starting to look, we're going to find. And so I don't think it's frustrating. I think it's just the beginning of the scientists really looking at this. And I think it's important, most important actually, to bring in neuroscientists with the immunologists, because it's going to be with the neuroscientists to find neuroprotective drugs.